filter into that area. A little cap of bone grows over and the gum tissue grows over, but you're left with a little cesspool of bacteria. So that's what a cavitation is. It's known by other names, and other bones in our body get it. The hip is the next most common bone to get it, but the most common is the upper and lower jawbone. And they most often happen after an extraction.
Do you mean of your wisdom teeth or any teeth?
Well, any teeth. The most common site is the wisdom tooth. There's a little ligament that supports the tooth to the bone. That ligament serves much like a shock absorber does. It's one of the reasons why you can take a healthy tooth, and if you wiggle that tooth a little bit, even a healthy tooth has just a little bit of movement in it. It's because there's a ligament supporting the tooth to the bone. In dentistry, when a tooth is removed, we should also remove that ligament. And oftentimes it's not removed. The ligament in itself precludes good bone formation. And there are a number of other things that we should do as dentists, in my opinion, to really get that bone to form after a tooth is removed. We need to really clean that socket well, especially if there's been an existing infection. And then we need to do other things, I think, to help make sure that that clot matures. We want a good, healthy blood clot in that area. And when a good, healthy blood clot matures, you will actually form bone. And that's what we're trying to do. Unfortunately, many times we extract a tooth, and the patient hops in his or her car and drives down some bumpy road getting home, and they vibrate that clot and dislodge it, and that is a recipe for a cavitation.
How interesting. How many dentists would you say around the country that you've had the pleasure to meet that are also doing this?
Difficult to say. When I started doing this 10 years ago, I wouldn't think there would have been more than just a handful of us, but I'm sure there are 100 dentists around the country at least that are cleaning these out now. It's very well documented in the literature. There are certainly close to 200 peer-reviewed articles on this subject. It's still not widely accepted. I think that we as dentists have a real difficult time accepting the fact that we need to maybe do a more judicious job of really robustly cleaning out that area when we remove a tooth in order to get good bone formation. But for the most part, I think at least the idea of cavitations has moved past the controversial stage and is more widely accepted now.
That's great. What is the issue with bacteria, and why is so much emphasis on getting rid of bad bacteria? There are a lot of people who would say, Doctor, there's so much bacteria in the body and in the mouth, you're never going to be able to get rid of it. Why is there so much attention to this area? For example, why do you not agree with doing root canals? Why don't you just leave it?
Well, again, a great question. The answer to that has recently become simple. Let me just back up. This idea of removing a tooth rather than doing a root canal is not a new notion. As long ago as 100 years, research was being done to determine whether root canal teeth still remained infected and whether they remained toxic. And that research was done by an incredibly brilliant man by the name of Weston Price. And he actually published 2 volumes, 1,200 pages, in 1923 dealing with this subject. Most of that research was shelved, and dentistry became convinced that we needed to save every tooth, and we're certainly trained that way. And we really have, from Weston Price, as you can imagine, 100 years ago, we didn't have any idea of knowing what bacteria were involved. How potent were those bacteria? But now we have that data because we're able to analyze the bacteria from a root canal tooth or from an extraction site or from a cavitation by DNA analysis. So now we can tell exactly what bacteria are in there. And the reason I think it's very important to have these cleaned out is because the scope of the bacteria and the magnitude of their toxins is absolutely amazing. And once again, I have to say, Kim, some people can tolerate those toxicities well, seem to tolerate those bacteria. At least we're not aware of clinical signs and symptoms that the people are undergoing. But others, of course, report after having had root canal treatment or an infected tooth or having developed a cavitation. Others report being ill. Now that we know the type of bacteria that are in there, it's easy to understand why, because they're some of the most potent anaerobic bacteria literally known to man.
Like botulism and other things, right?
Those bacteria that form botulism are called Clostridia botulinum. There are many different species of Clostridia, and certainly we find various species of Clostridia in these sites because they're anaerobic bacteria. They love to get in areas where there is not a good oxygen supply.
I would think that the dental community would be so excited to have these protocols available that they would integrate it as part of the standard of care and be excited about it.
Some of the challenges are that these protocols were developed years ago before we had definite scientific knowledge of the reason for doing it. In other words, the practitioners who began to put these protocols in place, in my opinion, were way ahead of their time. They were astute observers of their patients, and they determined over the years, they really by trial and error determined that, gosh, this protocol works better. These patients seem to heal better. These patients retain their blood clots after an extraction better. And so we had a series of practitioners over the years who developed protocols, but they were not mainstream. It's very difficult to turn a ship when you have 150,000 dentists in the country all trained a certain way, and a few so-called renegades come along and say, you know what, that's really not working well. It's very difficult for the mainstream to accept that until the scientific evidence catches up with it. In my opinion, the scientific evidence has definitely caught up with those protocols, and I honestly believe that the protocols that we're following today in terms of really trying to keep a patient as healthy as possible, I think the science is there to fully support those protocols.
Your partner talked about how in the standard of care in medicine, when a part of the body is dead, doctors would never leave it in the body. And yet in the mouth, it's part of standard of care to leave a dead tooth in the body, therefore requiring a root canal. So my question to you is, how many miles of the patient's tubules are in a tooth that needs a root canal, for example?
A front tooth has 2 to 3 miles of microscopic tubules in it that a dentist can never get to when he or she does a root canal. For example, a front tooth typically has one major nerve canal, and part of what a dentist does when he does a root canal is to clean out that major canal and fill it with a material, and that constitutes doing a root canal. In the course of that, the blood supply to the tooth is severed so that there's no way now for our own immune system to come and supply any of our immune system to it, any white blood cells and so forth. So the 2 to 3 miles of tubules sit there, and they are still filled with bacteria. And now the bacteria have a wonderful place to sit and multiply. And those bacteria now have no way of being confronted by our own immune system. So you have a wonderful incubator for bacteria to develop, and those bacteria then develop toxins. So we think of a tooth as being a solid
mass,
concrete almost, but it's not. It's porous. And so we wouldn't think of leaving something dead in the body. Anywhere else, you would most likely call that gangrene. But a tooth is porous, and it's filled with bacteria after having had root canal treatment. And that research is very, very well documented, even in mainstream endodontic journals, that there's no way to get all of the bacteria out of a tooth. And now, of course, with our DNA evidence, we know what bacteria are in there.
Doesn't this affect the heart and the brain and other areas of the body? And if so, how is it a detriment to the heart and the brain?
Well, those toxins, it's interesting to go back and look at Weston Price's research from the 20s, because there